Hello, everyone, and welcome to our first mini lecture on drug abuse and addiction. This is the introductory chapter, so let's go ahead and get into it. First off, we're not covering any of the historical stuff, though it is really interesting. If you've got some time on your hands, which you might, I would recommend reading it. It's very interesting, somewhat problematic. We'll touch a little bit on some of the issues with it, but not most. But it is a very interesting read, so I'd recommend checking that out if you'd like. Let's start off by defining what exactly is addiction. What do we mean by that? I have up here on the right side of the screen a list of some of the diagnostic criteria for the example of alcohol use disorder. You can see there are 11 criteria. Mere use is not a disorder, so something that we'll always come back to is that the use of the substance has to be accompanied by a severe impairment or distress. So merely using the substance, even if it's possible to become addicted to it, or many people are addicted to it, it is not considered a use disorder until it is accompanied by impairment or distress. There's no single criteria. We can't say something like, if you consume X amount of alcohol per week, then you must have an alcohol use disorder. It's different for every person. And this can be graded. What I mean by that is it's not an all or none thing. You're not either showing a substance use disorder or not showing it. You can just show mild, moderate, or severe depending on the number of symptoms that you are showing. It's the number of criteria that you meet. So let's talk through the progression of developing a substance use disorder. This is normally conceptualized in terms of 3 stages. There's the preoccupation anticipation stage, binge intoxication, and withdrawal and negative affect. So first off is preoccupation. So after your initial use and you're going back to use again, you have this sort of preoccupation, obsession, or sort of preoccupation with obtaining more of the drug. Occupies a lot of mental real estate. You're just thinking about obtaining and using the drug again. The second part of the cycle is binge intoxication, when you're actually using the substance and are intoxicated from it. And then after the drug's effects have worn off, you have the withdrawal negative affect portion. This is accompanied by a period of withdrawal symptoms and negative affect. And you can sort of follow the spiral here that leads to the preoccupation anticipation stage. So during withdrawal, you may be motivated to use that drug once again. And this cycle sort of repeats over and over again. It's pictured here not as a cycle, but sort of as a downward spiral, because that's how things tend to progress, with some mechanisms we'll talk about later on, like tolerance and escalation of drug use. You see things getting worse and worse with needing more and more of the drug, and the negative withdrawal aspect getting more and more severe as time goes on. So you see things like a persistent desire developing, and then social, occupational, and recreational activities being compromised. So again, sort of distress and ill effects from continued use. As the spiraling distress continues, you see the development of an addiction or a substance use disorder. There's not really one pattern for the progression of casual use into substance abuse. Bouts of abstinence and relapse are common. So over here on the right, we have sort of a number of different addicts in a study, just identified here by their addict number or by their participant number. And you can see here that they don't progress in a reliable way, and the use pattern over a lifetime is not consistent. People don't start using and just stay using for the duration of their lifetime. They might have bouts of heavy use or light use. They may be institutionalized and thus abstinent for that institutionalization period. They may be voluntarily abstinent after that, and they often don't stay abstinent. So you see sort of a pattern of heavy, light, and abstinence. There's a wide diversity of patterns. Some people will have an event-like institution, will stay clean for a long time. Some people will oscillate between heavy and light use for most of their lifetime. It's really, really variable. There is a bit of a trend that many people will mature out of use patterns. You see up on the top, participant number 149, participant number 71 sort of goes through a period of heavy use, then is institutionalized, and then sort of matures out at a certain age and stops use for the duration of the study. I want to speak lastly here about the Controlled Substance Act of 1970. I just want to mention this pretty briefly. This was the U.S. government's attempt to sort of establish a system to classify the abuse potential of drugs. This is a very controversial act even today. This was heavily politically motivated and isn't so much grounded in what we know now about some of these drugs. So as you can see, just sort of by looking over this table, there's a couple things that might stick out to you as where they're scheduled. So Schedule 1 is the most heavily regulated, with meaning that substance 1s have no accepted medical use and have a high abuse potential. That may surprise some of you, as marijuana certainly does have medical use. In fact, you can get a prescription for it, so it's a little out of place there. So that's just part of the sort of political aspect and the sort of slow to change nature of government regulation of drugs. Lastly, I want to mention here that routes matter. Those of you may some of you may remember from our first unit way back that we talked about pharmacokinetics and how certain routes of administration will allow drugs to reach blood plasma more quickly and to cross the blood-brain barrier and have their effects. Fast onset means quick saturation and shorter duration of action, so injecting something rather than consuming it through another route will allow it to become available much more quickly and reach high peak levels of concentration much more rapidly, and also have a much more transient effect. So things like IV and inhalation routes produce the strongest euphoric effects because of the rapid delivery. And because of this method of administration, repeated exposure and thus rapid delivery repeatedly can facilitate those neurobiological changes that are needed for addiction to develop. So administering things in a way that's going to result in rapid, hard-hitting delivery repeatedly is going to facilitate addiction development. And we'll talk about exactly how some of that works later on in this unit. All right, that's it for right now. I'll see you all next time.